It's called a How I Do It session. I suspect it would be more accurately termed a debate. My name is Howard Reber. I'm from UCLA. My co-chair, co-moderator is Markus Buchler, who is the professor of surgery at the University of Heidelberg. Our two debaters are people who are very well known to everybody in this room, and in fact everybody in pancreatology. The title of this debate is Adjuvant Therapy for Resected Pancreatic Cancer. Is there a role for radiation therapy? I suspect each of us has our own idea about that, but to begin, we're going to hear the affirmative position. Yes, there is a role for radiation therapy, and that will be presented by Doug Evans, who is the professor and chairman of the Department of Surgery at the Medical College of Wisconsin. Doug.
Oh, good. There's a screen down there. Yeah, I just want to make sure there was a screen down there. Well, thank you very much, Howard. Prior to starting, I just want to acknowledge, especially for the younger people in the audience, the contributions of Dr. Neoptolemos and Dr. Buchler. I think we'll hear about Dr. Beger tonight in great detail. But while I may disagree slightly with an occasional conclusion or two from the data, they have both really been prolific in their quest to solve the pancreas cancer problem. And certainly for that, I'm in tremendous admiration of both of you. Really a tremendous work. So I'm going to talk a little bit about radiation therapy, and I think this is the entire issue here. I think one of these is probably a pointer. As you can see here, the reason why radiation therapy was considered initially is from a basic understanding of the anatomy of the pancreatic head. And there are three margins that the surgeon has control over, if you will. The pancreatic transection margin, the bile or hepatic duct transection margin, and then lastly, and I would submit most importantly, the mesenteric root, or as we call it, the SMA, or retroperitoneal or uncinate margin, whatever you want to call it. But you can see that this margin is really measured in millimeters. And from my perspective, this is the entire operation. From a cancer perspective, assuming you can put the patient back together again, this is the entire operation. And I'll show you in the next 10 minutes what a problem this has been. You can have a positive margin in that area, both because you are unable to remove the entire tumor grossly, or as you can see in these white arrows, you have cancer infiltration of the autonomic neural plexus, which follows the arteries, as you know doesn't follow the veins, is a grossly visible structure. And this was probably the only Pancreas Club meeting that I've been to where there wasn't a basic science paper on perineural infiltration and the fertile environment that the nerves provide. I was recently in Houston, and this is a patient of mine that was discussed with me by one of the medical oncologists that, as you can see, has a local recurrence surrounding or involving the superior mesenteric artery. My reconstructed vein is completely occluded, and importantly, I think you can see down at the bottom that recurrent tumor occurred both at the level of the SMA, occluded the reconstructed SMV, also involved, you're not seeing it here, the pancreatic ojegonostomy. This was diagnosed last fall, and he has not flowered metastatic disease. This is the only site of recurrence. This, I think, is what we would like to prevent. And as was discussed earlier today in a larger expanded series, but the numbers remained the same, you can see that in the Hopkins autopsy series, 15% of patients died of only local disease. So this is not a disease where all patients die of systemic failure, and this is the logic behind improved local control for pancreatic head cancers. So to summarize my talk and then present a couple final points, positive margin resections are very common. I think all data, without reviewing this conclusively, but certainly in many manuscripts and book chapters, all would agree, occur in 25 to 50% of patients. And they confound the results of adjuvant therapy trials because very few investigators have the ability to determine whether they are truly providing adjuvant therapy, i.e. the treatment of presumed but radiographically occult micrometastases, or whether they're treating early recurrent tumor in the liver, lungs, occasionally bones, or incompletely resected disease. I think critically important to know that. Chemoradiation delivered to persistent, incompletely resected disease, R2 resection, is not adjuvant therapy. I think that's a critically important point to remember. Pathologists cannot tell the difference between an R1 and an R2 resection. Operative notes rarely contain information on the completeness of resection, and Matt Katz, if he's here, can talk about a paper he has in press on the ACKNOWLEDGEMENTS trial in this country, where only 24% of patients had information on the completeness of resection in the operative dictation. Unbelievable when you think about it. And if adjuvant chemoradiation is delivered, it should clearly follow systemic therapy. There really now is no question about that. If you're delivering off-protocol therapy or you're writing a clinical trial, one would typically deliver systemic therapy first. Those patients who fail systemically then will not receive chemoradiation and suffer the toxicity of local regional therapy with no benefit. So if you were developing the perfect adjuvant therapy trial, since, as I'll show you, we can't really rely on operative dictation, we also it's impossible to rely on pathology reports to differentiate R1 from R2 resections. You would like to first have preoperative imaging, define resectability anatomically based on that imaging, and I would argue from my first slide that this is not rocket science. You have two white spots, the SMV, the SMA, and you have a low-density tumor. We should be able to decide on what is resectable and what is borderline resectable. The resection margin, i.e. that SMA margin, needs to be inked and prospectively evaluated. And then most importantly, since, as I'll show you, we can't rely on the op note, we can't rely on the path report, you have to image the patient before entering them into an adjuvant trial if you're going to call it an adjuvant trial. Because adjuvant means the treatment of presumed radiographically occult micrometastatic disease, and you can see here that has not been done in recently reported trials except for the CONCO one. Even in the RTOG trial, in the true information eligibility criteria written into the protocol, they comment only upon distant disease, no comment upon local recurrence. And you can see here from ESPAC 1 and ESPAC 3 that patients were not re-imaged prior to entrance into the trial. So at least 50% of those patients had macroscopic disease at the time of trial entry. This is from Matt's paper concerning the ACKNOWLEDGEMENTS trial, and you can see here in those margins that were evaluated, SMA, common bile duct, pancreas, and then whether complete AJCC staging was performed. Look at this. Only 47% of patients had the only oncologically relevant margin evaluated. Now that would never occur in breast cancer trials, in rectal cancer trials. It really is a travesty, and it's something all of us in this room need to fix with respect to pancreas cancer trials. The concerns, and I think John will go over this in detail, but the concerns that were raised about ESPAC 1 were, number one, the fact that a modest number of patients actually received intended therapy, whether it be chemo or chemoradiation. And then secondly, local failure was a significant concern, raising the obvious question as to whether many of these patients had macroscopic disease, and this in fact was not a question of adjuvant therapy. When you compare that to a trial, a review that occurred at about the same time from Anderson, where a consecutive group of patients underwent a Whipple procedure, and 300 were R0, 60 were truly R1 and not R2, you look at the median survivals compared to the survivals in ESPAC 1, and I think that also raised the concern that these patients had macroscopic disease. And this survival of about 1 year is what you would expect from patients with stage 3 locally advanced disease who are treated with non-surgical therapies and in fact don't have an operation. So all of these issues raise concern that these patients had macroscopic disease. to show you some examples from this country of patients that I've taken care of. A 60-year-old man referred to Peter Pisters and myself when I was in Houston for the ACKNOWLEDGEMENTS trial. Operation was completed at a university center, comprehensive cancer center that you would all recognize, by a surgeon who's very well known. The op note had no comment on the completeness of resection, no comment on the tumor-SMA relationship. Path report reported a positive SMA margin, and he underwent restaging as per the ACKNOWLEDGEMENTS protocol, and you can see his CT scan at the time of restaging. This man's survival was 8 months from the date of this scan, 10 months from the date of surgery, and it was predetermined based upon the big chunk of cancer left behind adjacent to his superior mesenteric artery, nothing to do with the quality or the frequency of his adjuvant therapy. This is a man that I saw last fall in Wisconsin. In April of 2008, underwent a Whipple procedure, had adjuvant gemcitabine alone based upon the results of the ESPAC trials, and he developed almost a year ago now back pain and felt in his subcostal incision a wound implant. A nodule was appreciated on exam, biopsy positive, and started on Gemcitabine. And you can see the wound implant there. And this is his preoperative scan, and I just want to illustrate this because, again, the entire operation is in this part of the body. In his op note that I was able to get and review, you can see no clear description of the technique for management of the SMV, no comment on the SMA dissection, no comment on completeness of resection. Now, this is in a tertiary comprehensive cancer center, referral center in this country. This isn't in the middle of West Texas. And the path report was incomplete, and similar to most patients enrolled in the ACKNOWLEDGEMENTS trial, the path report had no description of the SMA margin. And you can see here, this is the bifurcation of the SMV into its first jejunal branch, low-density tumor involving that exact area. This is then further down, or caudal, and you see the jejunal branch exiting inferior to the superior mesenteric artery. Now, if you're going to take this out, this jejunal branch needs to be divided, and that segment of vein will need to be removed. This is not, in all likelihood, going to separate if you're actually going to remove this with curative intent. And sure enough, we repeated his imaging. His back pain was caused by a local recurrence. You can see his SMA. His SMV is occluded. Interesting to think about whether or not this natural history would have actually been changed with postoperative adjuvant therapy. I want to just briefly, in 30 seconds or less, just show you how normally one would manage that, because this is a patient that I operated on maybe 8 years ago or so, and you can see the same thing, tumor involving that jejunal branch if you go from cephalad to caudad, and especially for the residents in the room, this plane of dissection between the artery and the vein is developed, and that jejunal branch is divided, and then that segment of vein is taken out and put back together again. So I think critically important to answer the question of whether radiation therapy is important in this disease is to do trials where you actually know whether you're giving radiation therapy in a therapeutic or in an adjuvant setting. And to do that, patients have to be re-imaged. If you report a trial where patients are not re-imaged prior to entry, you don't know whether you're treating persistent or early recurrent disease or whether in fact you're giving adjuvant therapy. So what we do know, number one, and Dr. Reber would have been unhappy if I didn't bring this up, not everyone makes it to adjuvant therapy even if you wrote a correct trial. So as you know, from my perspective, I think this is the wrong way to approach this disease. I think we clearly, even if we developed a proper systemic therapy for this disease, it would need to be given before surgery and not after. And then patients with early recurrence or incompletely resected primary tumors probably do not benefit from chemoradiation, as demonstrated in the very well done ESPAC trials that I think Dr. Neoptolemos will comment in more detail. What we do not know is if adjuvant chemoradiation following systemic therapy, which is the way it should be given, will prevent local relapse and improve survival when truly given as intended as adjuvant therapy. And now in the gemcitabine era, it's important to remember that low dose, frequently given as fixed dose rate infusion gemcitabine, the doses that are given with radiation therapy clearly have systemic effect. This is one of many patients that were treated with low dose fixed dose rate infusion gem, and you can see that it clearly has a systemic effect. The current RTOG trial, and those of you in the audience who are involved in this can comment during the discussion section, actually tries to get at the radiation question. And you can see down below, the operating surgeon must document in the operative note that a complete gross excision of the primary tumor was achieved. The pathology report must include documentation of the margin status and the size of the tumor, and the patients are then restaged. So if this actually occurs, this trial and gets completed, this trial certainly would be a step in the right direction. This is the trial that was active in Houston before I left, and I think personally in this country, where patients are exceedingly educated, internet savvy, have oftentimes done PubMed on those of us who they're seeing, this would be an excellent way to also get at the radiation question. And you can see, look at this trial. Pre-op gem-erlotinib and radiation, pre-op systemic therapy without radiation. Patients then get operated on, restaged, and then further systemic therapy. For those who did not get radiation pre-op, radiation is an option post-op if there in fact is an R1 resection. My concern with the RTOG trial is that after restaging, patients will in fact be concerned about not receiving the experimental arm at that second randomization. But I think with that, I'll stop and yield to John. Thank you very much for your attention.
Thank you, Doug. Ladies and gentlemen, our next speaker is Professor John Neoptolemos, who is the chair of surgery at the Department of Surgery at the University of Liverpool in the UK. He will present the data that speaks against adjuvant radiochemotherapy. Please, John.
Okay, in the true spirit of a debate, I would also like to acknowledge the tremendous contribution that my opponent, my protagonist, has made to the field of pancreas cancer surgery. I was very grateful for his opinions. Before I give you some evidence, however, I would like to mention colleagues that have really changed the field of adjuvant treatment in pancreas cancer, namely Professor Hans Beger, who we are acknowledging later on this evening, Professor Markus Buchler from Heidelberg, Professor Claudio Bassi from Verona. I think these people have really changed the way we think about this disease. I'm not going to give you my opinion, I'm going to give you some level 1 evidence. What we've heard just now is level 5 evidence. If he was a radiotherapist, it would be level 7 evidence, but it wasn't bad. We had level 5 evidence. So by level 1, I mean randomized controlled trials with or without some meta-analyses. All the meta-analyses here were actually conducted by the group in Liverpool, the ESPAC trials you already know about. So what facts do we know? Well, if you give chemotherapy in advanced cancer, it's better than no chemotherapy, and by that I mean survival. If you give chemoradiotherapy versus no treatment, there's been one small randomized study, and that is better. If you give chemoradiotherapy, meaning radiotherapy with chemotherapy at the same time as a sensitizing agent, it is better than giving radiotherapy alone. But if you give chemotherapy versus chemoradiotherapy followed by chemotherapy, these 3 trials show no difference. More recently, that meta-analysis has been updated by a randomized controlled trial from France. I know many Americans dismiss France, and we do in the United Kingdom most of the time, but on this particular occasion, we take cognizance of this important trial, 120 odd patients. And the interesting finding here was that patients who had chemoradiation followed by radiotherapy had a median survival rate which was nearly half that of those that just received the chemotherapy. You cannot dismiss these data as being some kind of French aberration. And our colleagues from Japan have shown in a small randomized controlled study that even surgery is better than chemoradiation for locally advanced disease. So, coming on to ESPAC 1. When we started the study, the largest adjuvant trial that had ever been conducted in pancreas cancer comprised of 43 patients. So people said to us, well, you know, you're going to have trouble recruiting. So we adopted a very clever trial design. It's called a 2x2 factorial design, and basically you randomize patients both ways. And I have to say, Doug Evans, amongst others, gave us a tremendous amount of stick, bordering on the abuse, because they said this was an unacceptable trial design. And I'm delighted to see that 15 years later, the RTOG have now also adopted a 2x2 factorial design, as just been shown to you by Doug Evans. But it's a clever design because it enables you to ask two important questions by randomizing patients twice. The independent data monitoring committee that was overseeing ESPAC 1, who could look at the data, but we as investigators couldn't, said to us in 2001 we had to publish the initial data because chemoradiation, frankly, was dangerous and it should not be administered on ethical grounds to any further patients. So that was the initial publication. The second publication just focused on the 2x2 factorial design patients, some nearly 300 patients, and this confirmed that this is chemoradiation, this is no chemoradiation. Chemoradiation was not good as adjuvant treatment for pancreas cancer following resection. The final data also confirmed that chemotherapy, and we were just using ordinary 5-fluorouracil bolus here, was better than giving no chemotherapy. Quality of life, and this has been looked at intensively, showed that it improved after surgery and it improved similarly for both chemotherapy and non-chemotherapy. So that's a very important point. We received a lot of stick, again a lot of criticism by that somehow radiation treatment was inadequate, that we were including a lot of advanced disease patients and all the rest of it. But when you break this down, you can see that the chemotherapy, median survival of 21.6 months, 5-year survival rate 29%, was actually better than other studies published, and the median survival rate of 19.9 months was better than most other American studies using chemoradiation therapy. And this was intention to treat, and as Doug Evans has rightly pointed out, you know, that in a large randomized controlled trial, you'll always have approximately 10% of patients who receive no treatment, and an additional maybe 10 to 15% who receive a reduced dose because of the performance status of the patient and the criteria that are necessary to give the chemotherapy and other treatment. So despite those handicaps, we were still achieving outstanding results. And there was resistance in accepting these data initially. So this was a meta-analysis undertaken of other studies, and again, this shows that chemoradiotherapy is of no benefit, no benefit. Unless you're a radiotherapist charging for the treatment, it's of no benefit to the patient. And that's your survival curve. There's no benefit for giving chemoradiotherapy. And again, it's the red curve. Okay, again, meta-analysis of chemotherapy. Again, this confirms a benefit for chemotherapy. Again here, the chemotherapy here is the red curve. These are large numbers of patients. They're not 20s and 30s and 40s. Okay, so this is the RTOG 9704 trial, recently published in 2008 in JAMA. And here what they did was they gave chemotherapy, the 5-FU or gemcitabine, consolidated with 5-FU-based chemoradiation, and then continued with either 5-FU or gemcitabine, depending on the initial randomization. You'll notice that they actually randomized 538 patients, but only analyzed 451 for various reasons. So this was certainly not an intention to treat study. So you're already beginning to sub-select out. Overall, there was no significant difference. They did their best to find a difference. So they just looked at the subset of patients with head of pancreas tumors, and it was still not significant. Still not significant. And you can see it for yourself. This is all patients here. These are patients with head tumors. And I'm not sure how a journal like the Journal of the American Association of Medicine can allow this conclusion, but this is what was concluded. The addition of gemcitabine to adjuvant 5-FU-based chemoradiotherapy was associated for a survival benefit in patients with resected pancreatic cancer, but it was not statistically significant. You know, I have to sort of read it over and over again, but that is true. So I didn't copy it, I actually cut the photo out. And when we look at the comparators here, you can see this is the RTOG 07. You can see that their chemoradiation, which they say is the best in the world, achieves with 5-FU a survival which is similar to observation. This is repeating the data from ESPAC 1. And even with using gemcitabine here, it's not much better than what we gave in ESPAC 1. So where is the substandard radiotherapy that was given in Europe? Where is it? Intention to treat, 10% of patients never had any treatment and the other 10% had reduced treatment. There is no question that ESPAC 1 is in any way inferior in terms of either its trial design or the treatment actually delivered. And if we look at 3-year, you can see the results by giving radiotherapy are actually inferior 3 years to 2 years doing nothing. Okay, and that's the result there. Now, okay, it's a little bit unfair comparing one trial, patients from one trial with another trial, but you cannot say that the treatment given in ESPAC 1 was in any way inferior, either for radiotherapy or chemotherapy. So this is the CONCO 1 trial undertaken in Germany. This was a straight comparison between gemcitabine and observation. They excluded patients with a CA19-9 more than 2.5 times the upper limit of normal. Therefore, they super selective for a group of patients who would do a lot better. And their primary endpoint was disease-free survival, and they confirmed the benefit for adjuvant chemotherapy, as you can see here. And this next slide here shows you the results of overall survival and disease-free survival. In fact, on further follow-up, that has become significant. This is the ESPAC 3 trial. We presented this at ASCO last year, and we're in the process of trying to get this published now. Over 1,000 patients in this single trial. The median survival here is between 23 and 24 months. In this trial, 35% of patients were resection margin positive. Median tumour size was 3 centimetres. 24% of patients had poorly differentiated tumours. And 72% of the patients had positive nodes. This is a proper series of patients, as I would say. If we look at some of the prognostic factors here, this is grade, this is stage, this is by lymph nodes, and this is by resection margins. For Doug to say that people with R1 positive tumours do not survive is incorrect. These are all patients here, 35% had R1 positive tumours, and with adjuvant chemotherapy, there was a good survival going out to 5 years. Not where we would like it to be, but it's certainly not 0. there was a criticism that we couldn't compare 5FU with a strict non-observation arm. And in fact, we now have nearly 460 patients from the combined ESPAC1 and ESPAC2, a group of patients where we can directly compare 5FU with observation. Now, this is extremely important because this tells us that patients with pancreas cancer in the adjuvant setting respond equally to 5FU and equally to gemcitabine. So if you fail one, you can use the other, and more importantly, as we're testing in ESPAC4 now, we're looking at the combination. Okay, so I'm sorry to put this up again, but it is necessary. So here we have results from ESPAC1, ESPAC3, CONCO1, and RTOG 9704. And the criticisms that I've raised before about there being no evidence, whichever way you want to look at the data, the radiotherapy data in the adjuvant setting is not good enough. And if this was any other cancer, you would not be using radiotherapy. It could be that radiotherapy clearly interferes with the delivery of systemic chemotherapy. You know, and any medical oncologist worth his salt will tell you that you have to give the chemo for 6 months, because you kill the tumor cells, they proliferate, you kill the tumor cells, they proliferate. And this is old work. You know, we don't have to revisit old clinical work as to how cancer behaves. You only kill so many cells every time you hit them with chemo. They proliferate, you hit them again, you hit them again, you hit them again. And it's between the 3 and 6 month point that you're actually beginning to eliminate the cancer stem cells. So if you interrupt that process by giving radiotherapy to just a localized area, you're in trouble. Because cancer is a metastatic disease, we know it goes to the bone marrow in nearly every patient, and that it's things like that that probably, that kind of dissemination that probably kills patients. Now, Doug was touching on the issue of neoadjuvant therapy. That's not, neoadjuvant therapy is not the same as neoadjuvant radiation therapy, and we will try and address this in ESPAC5. So this is what the JNCI said, Doug. Lots of talk, but where are the data? There's a 2-page editorial to say, where are the data? And we're still asking that question. So this is ESPAC5. We're going to try and look at the neoadjuvant question, not to be confused with radiation. Say thank you to a few people, patients, and my wife who let me out this weekend. Thank you.
Thanks very much, John. We'd certainly like to leave time for questions from the audience, but let's ask Doug to go back up there now. And John, why don't you stay there as well? And first give Doug an opportunity to respond in a minute or so, really very briefly, to anything that you'd like to say, and then we'll afford John the same opportunity.
The only comments, I agree with, I'd say 95% of John's presentation. I think the area where I disagree is that we haven't studied the issue of adjuvant therapy, and that hasn't been looked at. I think the fundamental global mistake is it's illogical to think that all of these patients, that radiation therapy is a logical strategy for all these patients. Obviously, what happens when you complete a Whipple operation? A significant number of patients don't recover, so they don't make it into ESPAC1, ESPAC3, etc. Number 2, you have a number of patients who experience early recurrence. Number 3, there are patients who have persistent unresected disease. The issue of adjuvant radiation therapy is not pertinent to those patients. Where it's pertinent is to the patient who has a gross complete resection, R0 or R1, who then gets systemic therapy. Typically in this country it would be for 4 months with restaging evaluation at 2-month intervals, and then has a negative restaging evaluation, a good performance status, a lower risk of systemic relapse. That's the patient. You want the next series of Hopkins rapid autopsies to not include 15% of patients who have local relapse and die of that disease. The question is, in a selected subset of patients, is there a role for adjuvant radiation therapy? No one is arguing that it's a proper treatment for all patients. I think with regard to the ESPAC data, I think the unanswered questions basically are two. Why did the patients with chemoradiation do worse than observation? What is the pathophysiology of that? And then what were the survivals of those patients by actual treatment? In other words, in the patients randomized to receive chemotherapy, what were the survival of those who did receive chemotherapy compared to those who didn't? Understanding the issues of intent to treat.
John, do you want to say a word also?
I don't want to get into details because all the questions that have been raised about ESPAC have actually been raised, and I think we're getting down into small details, and there isn't anything to actually detract from the quality of the data there. The data have been confirmed by CONCO. The data have been confirmed by ESPAC-3. We're now dealing with over 2,500 patients. No such data exists for radiation therapy. The point that Doug made actually is an interesting one. The criticisms about adjuvant radiotherapy are as it's used now. What Doug was saying was quite different. What Doug was saying there is that we should give chemotherapy for 4 months, and then if there's no recurrence, consolidate. Now that's a different question altogether, and that is the trial that should be done. Okay, that's a trial that should be done. But we've never had that trial, and that's a different type of question.
Yes.
So if Doug's conceding that we should not give chemoradiation in the way that it's been given up to now in the United States, then we have considerable agreement.
Okay, John, thank you very much. Doug, why don't you go back up and then we'll begin to take questions. And the first will be from Professor Buchler.
Yeah, thank you. Doug, I have one question to you. Your job was to speak in favor for adjuvant radio chemotherapy, but you didn't do this. You were giving arguments for future trials to be designed, and you showed CT images of single patients that responded to whatever kind of treatment, but I didn't find one argument in favor for adjuvant radio chemotherapy. Does this mean that there are no arguments in favor?
Well, first of all, let me just explain that I spent most of my time in the locker room, and therefore I didn't have time to make it to debate club. But that was a little joke, but everyone's asleep. I wanted to emphasize the fact that this question has not been studied. Because if truly the question is adjuvant, and I know I beat this to the ground, but it's critically important. If the question is adjuvant, the only trials that are interpretable are those that evaluate patients prior to trial entry. And if you haven't done that, you're treating persistent gross disease and early metastatic disease, which confounds the results, because everyone appreciates the fact that it's the minority of patients who will benefit from further enhanced local regional disease control. And that's why I think the rapid autopsy data is right to that point.
Okay, why don't we then begin with Dr. Traverso, go back and forth across the room.
Doug and John, thank you very much for preparing these talks. And John, thank you for your wife allowing you to come. Because you may not know this, but John is a competition dancer, and he and his wife are in an international league and it was just yesterday or the day before.
We have 3 minutes till the end of this session.
So my question to both of you is, all of our results are bad. If you compare them, one's a little bit better than the other, but they're all bad. And the future depends upon how well we can work together in a global sense. Thanks to Boeing and Airbus, we can do this very easy. I'd like to hear how our results can get better with novel new drugs, with novel ideas, but I think the main enemy is us. We're very diverse in our thought patterns, and since Fortner and his extensive resections, extending into Japan and their extensive resections, our adjuvant therapy, and now with novel new drugs, clearly we've got so many variables to test. First thing we have to do is get together, and how can we do that?
I think you hit it on the knuckle there. No patient, if you're in an academic centre in a large community hospital and you're resecting reasonable numbers of patients, every one of those patients should be going into a trial if they're up for it. And some local trial, some local study to do this or that at the end of the day isn't going to achieve much. You know, I make exceptions to important phase 2 studies, the vaccine work at Johns Hopkins and so on. You know, this is important work of a different sort, but for the vast majority of us, it's going to mean answering important questions. The problem in North America seems to me have been, and I do have radiotherapy friends, by the way, but not many, is that they have a grip of the adjuvant situation, and it's stopping interesting assessment of novel approaches. And this is what really needs to be done now. I mean, in Europe, we've gone for gemcitabine plus capecitabine, not because we didn't want to use any more exciting drugs, but that at the end of the day, you've got to negotiate with drug companies, and that's what we've ended up with. Perhaps in North America, you've got other opportunities. But radiotherapy is actually, I think, creating confusion. Instead of answering the key issues, what are the new biological agents that we can effectively use with 5-FU, capecitabine, you know, gemcitabine, whatever. And you can actually be doing 2, 3 or more of those studies now in North America. And I know the NIH would support you doing that.
I think before we do anything, we need better discipline. The op notes have to be standardized, the path reports have to be standardized, and we need to have a templated system for interpretation of CTs. I think doing more trials without those 3 issues is just going to give you confounding results. It just is not going to be adequate, and I think that you know, if we're going to give A's to effort for everyone who takes a patient to the operating room, and then just test systemic therapy on a heterogeneous group of patients, then fine. But that won't answer the adjuvant question, which was the topic of this session.
Doug, just one question more. You know that in Europe we have consensus now that most of our surgery is R1. You think that what we can do is R0 in 80% of our patients. We strongly disagree with that. If you do the 3-dimensional pathology, you will come up with 80% R1 in the patients we operate. This is one. The other thing is, you said a pathologist cannot differentiate between R2 and R1. I would also strongly disagree with that. Pathologists can very easily differentiate between R1 and R2. Or what kind of pathologists you work with?
We do have a fundamental disagreement on the T stage issue. With pancreas cancer, the T3 designation is for those margins that are not surgically created. In the AJCC and the UICC, since I've been heavily involved in those chapters, I know pretty much every letter. That's T stage. The R stage gets to the surgically created margins, pancreas, hepatic duct, and the SMA. I can tell you from spending about 15 years with residents who have trained all over the world, there just aren't that many people who routinely expose the superior mesenteric artery, who fully mobilize the SMV portal vein confluence, and then have that margin accurately inked and evaluated. That is the surgically created margin that is most prone to persistent, grossly incompletely resected disease.
I think we're going to have to end the session. Is it all right, Bill? All right, Len, let's take questions from the two gentlemen who are at the microphone, and try to keep your answers short, please.
So I just wanted to make the point, you know, in ESPAC 4 we have very strict pathology criteria. We have a whole page registration form. We have a protocol for the pathologists to follow. They use 5 different paints. We clearly define what an R margin is. You can control all these things. I don't see how writing better notes, Doug, is going to give you better results. I mean, your results are no better than anyone else's, and you must write the best notes in the world. That doesn't help you. What's going to help you are actually going in and looking at new agents and using them in an interesting sort of way.
Massimo?
Sorry, John. You didn't mention that in the subset meta-analysis, some advantages regarding chemoradiotherapy was, at least seems to be for R1 patient. Which is your actual position as regard this point?
I think it was a suggestion. It wasn't, you know, I mean, in Italy, if you have a red traffic light, stopping is a suggestion. And, you know, it was similar here.
John?
Just finish up. I enjoyed the debate. Dr. Neoptolemos, you slid by the one slide at the end about the borderline resectables. Is there no radiotherapy plan for that?
We're looking at that. We'll probably randomize into radiotherapy versus straight up chemo in the neoadjuvant. This is it's taken a number of years to get to some kind of consensus, but we're now close to having a consensus for a neoadjuvant trial.
So you're not convinced totally that radiotherapy is no good?
Well, I think in the neoadjuvant context, because then there may be a case for looking at it. There is still a question mark. Post-operatively, no.
Thank you, John. Ladies and gentlemen, we have to close this session. I think this was a very nice debate.